Hello, everyone. Welcome to our webinar. Today, we will be discussing moving from data collection to action, improving patient access to SDOH resources. Thank you all for taking the time out of your schedules to join us for an informative webinar, which is supported with funding from HRSA's Bureau of Primary Health Care. And this is part one of a national webinar series, so this is part one of four. All right. Getting into some housekeeping for you all to ensure that everyone has a smooth experience during the webinar. I'd like to go over some housekeeping with you all. So in terms of these housekeeping rules, we ask that all participants are muted on entry to limit background noise. We ask that you use the Q&A or chat box to ask a question during the session. We will be monitoring the chat. This webinar is being recorded, as you all can see, and materials will be emailed to all participants. We would love to hear your feedback, so at the end, please fill out our brief evaluation at the end of the session. Alrighty. So in terms of the Social Determinants of Health Academy, the SDOH Academy, it was founded in 2017. The SDOH Academy faculty created a set of foundational trainings available to all health centers and continues to offer a variety of learning opportunities on identifying and addressing social needs amongst health center patients. The collective efforts and expertise amongst SDOH Academy faculty members is what makes us unique and impactful. I encourage you all to visit our website, sdohacademy.com, to view resources and recordings of trainings and events. Next slide, please. Alrighty, so I'd like to provide a brief overview on National Training and Technical Assistance Partners, also known as NTAPs. HRSA's Bureau of Primary Health Care funds NTAPs to develop, deliver, coordinate, and evaluate training and technical assistance, also known as TTA, for existing and potential health center grantees and lookalikes. Each NTAP is unique in its offerings and area of expertise. However, each NTAP is well equipped to support health centers provide the best care to their communities. Next slide, please. All right, so on this slide, you will see the logos of the 18 NTAP faculty organizations that make up the SDOH Academy. We encourage you to visit their respective websites to learn more about them. This first webinar was coordinated by the Corporation for Supportive Housing, the National Association of Community Health Centers, the National Center for Medical Legal Partnership, and the National Center for Equitable Care for Elders. So I'd like to introduce the speakers for today's presentation. My name is Chloe Destinoble, and I serve as a project manager for equitable health and well-being at NAC, and I am currently on the Population Health Division, specifically the SDOH team. Next, you will hear from Jamie Blackburn, Senior Program Manager at the Corporation for Supportive Housing. Finally, we are excited to have Sonia Deal, Vice President of Community Health and Engagement at Affinia Healthcare in St. Louis, Missouri. She will share how she and her team have leveraged SDOH data to address the housing needs of patients. All right, so getting into the learning objectives for you all, as you may have seen when you registered for this webinar, by the end of this session, we would like to be able to understand factors that limit or prevent access to needed health services for priority patient populations, describe the value of prioritizing enabling services to improve health outcomes, including utilizing community health workers, also known as CHWs, to address non-medical health needs, and finally, incorporate strategies to leverage SDOH screening data to establish effective partnerships and referral networks. So I'd like to take a moment To ground us in a powerful quote from Dr. Geiger. He was a physician and civil rights advocate who helped launch the American Community Health Center movement. Though some criticized a model of healthcare that incorporated social, educational, and economic support services, Dr. Geiger believed addressing health disparities was a crucial importance to the health and well-being of patients. And before we take a deeper dive with our panelists today, we wanted to begin by level setting. So when did this conversation begin? The quote reads, "The last time I checked my textbooks, the specific therapy for malnutrition was in fact food." All right. So there are several ways to spell out the acronym SDOH, but they all point to the same thing. These are non-medical factors that influence a person's health outcomes. These are the conditions in which people are born, grow, live, work, play, and age. These conditions are shaped by the distribution of money, power, and resources. So SDOH is neither positive nor negative. Each person is impacted either positive or negatively by social drivers or determinants of health. And as you can see, healthcare only makes about 20% of that. Everything else is SDOH economic wise, physical environment. Right. So another helpful way to understand and visualize these non-medical factors is to use the American Hospital Association societal factors that influence health framework, which starts from the individual's social needs and expands out to determinants slash drivers found within their community. And then even further to the more fundamental systemic causes of health inequities. All right. So HRSA has developed a conceptual framework focused on health center excellence, both to support innovation and improve performance. One of the 7 domains is population health and social determinants of health, which emphasizes the role of health centers in providing comprehensive services to address social needs. On this slide are listed performance expectation areas that illustrates the priorities for population health and SDOH within HRSA's framework. These are the bullet points. It's population needs assessment and management, community needs and resource mapping, resource allocation, community partnerships and collaborations, and track and close social service referral loops. A health center excelling in this domain understands the social risk factors and needs in this community and collaborates with a wide variety of partners to address key drivers and improve health equity. Okay, so most people are familiar with Maslow's hierarchy of needs, which categorizes our physiological and psychological, needs from the most basic to the most complex. As we think of the health disparities and inequities in our own communities and across the country, we can see that having unmet foundational needs, which is at the bottom of the pyramid, will limit the ability to focus on needs within the higher needs, or at the top, as you can see, of the pyramid. Inequalities at the foundation level will impact a person's ability to actualize their full potential. Next slide, please. So another framework I'd like to reference is the Healthy People 2030. The SDOH Academy has intentionally leveraged this framework over the past couple of years to show how health center efforts align with this important federal framework. Okay. So within the framework are 5 different components, and one of them is health and safety, and they are health and safety promotion, environmental health, transportation, physical activity, injury prevention, and safe, affordable housing, one of which is the neighborhood and built environment. All right. So this domain includes objectives for improvement that are listed on the slide. As you can see, safe, affordable housing is important within this domain. This objectives has three measures that are critical to understanding the impact being made within this domain. So please note that these measures are community-wide improvement and not specific to health centers. However, these measures provide an idea of how and where health centers can align with community partners to ensure safe, affordable housing in their communities. All right, so at this time, I'd like to introduce Jamie Blackburn, who is the Senior Program Manager at the Corporation for Supportive Housing. She will be sharing a wealth of knowledge and expertise related to housing and a built environment.
Thank you so much, Chloe. It's very nice to see everyone. Good afternoon. As Chloe just mentioned, I'm going to be talking to you all today about housing as a driver of health and zooming in on housing as one of the primary and powerful drivers and social determinants of health. Certainly, there are so many social drivers that we could talk about that were mentioned in the framework. Transportation insecurity, food insecurity. But for the purposes of today's webinar, we're really going to spotlight and zoom in on housing as a powerful driver of health. And so I do see folks continuing to put questions in the chat. Definitely continue to do that. I'm happy to stop at any time to answer your questions, but let's zoom in. So what do we know from the most recent UDS data for 2022 that sort of speaks to a little bit of housing insecurity or homelessness that we're seeing amongst our patient population? So we know that 94% of federally qualified health centers across the country either are already screening for social determinants of health or have plans to implement a screener, such as Prepare or otherwise. That's the most popularly used, but certainly not the only one. There's over 1 million, about 1.3 million patients that have indicated that are experiencing homelessness, another just over 500,000 being screened for housing insecurity. So either at risk for homelessness or they have unstable housing that is unfit for human habitation, perhaps, or perhaps they have economic insecurities that lead to their housing situation being precarious for families. We see a lot of what this means is being doubled up. So multiple families living within a certain situation that normally would only be for one family. That's quite common, and certainly these numbers are not reflective of what we know to be the bigger picture. This is certainly only a snapshot. We know that there's the number of outreach workers and the number of those that are doing enabling services are going up. So we have about 2,000, about 2,700 outreach workers, that roughly about two per health center, about 2,300 CHWs, community health workers, roughly 1.38 per health center, and over about 2.3 million patients receiving, enabling services. On our next slide, you can see this map that we've created. Now, this uses 2021 UDS data rather than 2022. But the numbers have not shifted that much, so you still get an idea. This shows where that spread of patients, federally qualified health center patients that are either experiencing housing instability or homelessness, according to UDS data, are spread across the country. I imagine that this doesn't come as a surprise to many folks, certainly anecdotally in our own communities every day. I'm sure every one of us has a story about families struggling to find affordable housing, people struggling to find affordable housing in their communities, even in places where traditionally cost of housing has been a bit more affordable. Outside of those sort of coastal areas or bigger cities, we're seeing this all over the country, all the way into rural areas as well. And this map sort of, reflects this trend. Homelessness and housing instability are increasing across the country. So I'd like to hear from you all in the chat. Let me know, how is your health center currently addressing, and you can go to the next slide, please, Rayhat. How is your health center or organization currently addressing SDOH needs, and if certainly we're spotlighting housing, I'd like to hear if you are working on housing. Tell us in the chat. What are you doing presently? If you are one of the 94% of health centers across the country that are screening for SDOH, okay, I see Jennifer in the chat. We're just starting to gather the data. A lot of health centers are just in that stage. We're gathering this data. We're starting to understand the housing needs of our patients. So we're starting to figure out, how do we build out those referral networks? How are we addressing this? Yep, I see a couple different. We're making referrals, partnering with local shelters. I see other folks. A lot of people just beginning to gather the data. I see some folks using CHWs. Excellent. Looking for alternatives for housing, making referrals. Excellent. Oh, I do see. Shout out to Donna for saying that they have their CHWs participating in their local continuum of care. We're going to talk about that. Excellent. Thank you. Section 115 waivers. Excellent. Okay, that's Medicaid specific, about how you can tap into Medicaid dollars to fund tenancy support services. Excellent topic. Okay, so there's a wide variety of responses that people are taking to address SUH needs. It's complicated, and it's complicated further by where you are located in the country, whether you're in a Medicaid expansion state or not. There's many factors that can go into the strategies that you can deploy in your state level resources. But that's what we're going to dive into. Thank you. Keep it coming in the chat. So building on our previous conversation about social determinant of health framework and healthy people, we know that neighborhoods impact health. So it's not just the housing itself, but it's the actual environment and the neighborhoods upon which people are living in. Substandard housing, limited economic opportunity, limited transportation, food deserts, all of these compound, which then create all of these barriers for the patients that we're inevitably serving. And health centers play a really pivotal role in trying to disrupt this historical precedent where we see this sometimes concentration of substandard housing. And certainly we know FQHCs are charged as those safety net providers, those anchor institutions in their communities to reach these individuals. So talking about SDOH is baked in to the mission for every health center. Now, when we talk about housing as a determinant of individual health, there's certainly such a strong evidence base that links housing as one of the most basic and most powerful drivers of health. And this is reflected back in, Chloe mentioned the Healthy People 2030 objectives. One of those objectives aims to reduce the number of families that are considered rent burdened. So rent burdened means you're spending more than 30% of your income on housing at any time. And so the fact that this is being sort of explicitly stated as goals, that we need to bring down this number of folks that are disproportionately paying more of their income towards housing as a way to improve health, right? Because when you have more economic wiggle room that you can and you have stable housing, you're more apt and you're more willing and able to focus on chronic health care. You're more likely to follow up with your healthcare provider, medications, all of these things. And then when we talk about homelessness, so there's housing instability, and then there's actual literal homelessness for individuals who have experienced homelessness, especially long-term or chronic homelessness. There's accelerated aging, and there's a very, very, very strong evidence base that shows the impact of lived homelessness on long-term health outcomes, longevity, and ultimately lifespan. So this is, housing is a very powerful determinant of health. And anecdotally, not just anecdotally, we also have many data sets that show this too, but we hear over and over and over again from our health center partners that housing is the number one issue. How do we get folks connected to housing? And it's more challenging than food insecurity or others, because housing, the way it's structured, the way it's funded, how you can tap into those resources. We know that 1 in 4 folks in the United States who are eligible and need rental assistance can access it. So only 25% of folks are actually getting things that they need. The average wait time for housing assistance, so that's public housing, that's housing choice vouchers, commonly known as Section 8, that's 2.5 years. 2.5 years is the average wait time, and that's among people who actually were successfully housed. In reality, it's much, much longer because most people drop off the list and never actually get housing. So 53% of public housing authorities across the country don't even have an open waiting list. There's so many people on their waiting list, it's closed. And this map here shows where there is the biggest shortages amongst those that have the most extremely low income, right? And so there's a shortage of housing options across all income spans, so from workforce housing down to those experiencing homelessness. But this particular graph, this particular map shows where those discrepancies are for those that are defined as extremely low income, with the red states showing where the is most dire across the country. And you can go to the next slide, please. Why is it so challenging, though? Why is it that housing continues to be confusing, intractable, and that health centers continue to struggle with tapping into what resources are available? Why is there such long waiting lists everywhere? And the short answer is that housing is not funded as an entitlement. What does that mean? Unlike something such as Social Security, affordable housing isn't guaranteed. It's funded through Congress funds rental assistance through annual appropriations. They have to provide sufficient funding with increases for inflation every year. It's vulnerable to cuts. And furthermore, it's funded through a patchwork of different funding streams, right? We create a little carve out for people over here that we think are worthy. We create another carve out over here for people that we think are worthy of housing. So if you're a senior, if you meet this very narrow definition of homelessness, if you're living with HIV/AIDS, if you are a veteran, if you are an unaccompanied transition age youth, we create all these special carve out programs instead of acknowledging that housing is a universal human right and funded as an entitlement. And therefore, we're constantly under a shortage. And then further compounding the issue is that because these are funded through a patchwork of government agencies and different sources, they each have their own reporting requirements, eligibility requirements, which layer on the complexity for service organizations and housing providers that are administering these programs. And so it creates barriers. And then folks are charged with navigating these pathways. There is no one standard application for housing. You have to apply through many different pathways, meet all these different eligibility requirements. So not only does that make accessing the housing for the patient and the individual and the person navigating for them difficult, it also becomes extremely difficult for organizations that are interested in creating new housing because that requires them to blend and braid many different funding streams in order to get a single project off the ground, which takes many years to get one successful project that might add 150 housing units to one community off the ground because we refuse to acknowledge housing as a right and fund it accordingly. So from a healthcare perspective, we understand collectively that SDOH is that social drivers of health are deeply impacting health outcomes and are deeply impacting and affecting areas that would normally be under our purview. We are expected to try to help move the needle on a lot of these different health outcomes. But those health outcomes and the conditions that affect that are driven through other sectors that healthcare doesn't have much effect or doesn't have direct influence over, creating what we call the wrong pocket problem. We know that housing affects health, affects patients' ability to take care of their health, to access health. But how do health centers how do we play a role? How can we get in the game, so to speak, to address these things in a really comprehensive way? And the answer to that is we need new partners, new resources to address this, right? Partnerships, cross-sector partnerships. and this strategy is reflected in, I don't know if you've had a chance to take a look at the new federal strategic plan to end homelessness. It's really fantastic. Take a look. But just to lift up one of the strategies, this is being reflected back in many of our federal strategies, that partnerships across sectors, so between healthcare, aging and disability services, and then housing providers, is one of the main strategies in the new federal strategic plan to prevent and end homelessness, reflecting back this wrong pocket problem and the need for cross-sector, the ever-growing need for cross-sector collaborations. And then not to back up this federal plan, I will say that there has been new funding that's been put out through HUD, so the Department of Housing and Urban Development, encouraging these cross-sector partnerships. So in 2023, $486 million in new grant funding was distributed to address rural and unsheltered homelessness. Now it's being distributed out through continuums of care. And if you don't know what that is, we're going to talk about that in a second. Which is the homelessness response systems in your local community. Every community has one. But what's unique about this funding is that it specifically incentivized and encouraged homeless response systems to partner with healthcare providers in their community. And federally qualified health centers are especially positioned to act in this capacity because there's just so much mission overlap between a COC and what an FQHC is, especially when we're talking about SDOH. So let's talk a little bit about, I saw a lot of great comments in the chat about some of you are already utilizing, the community health workers, CHWs to address SDOH needs. I saw quite a few folks talking about utilizing them, leveraging for screening, which is fantastic. But let's just real quick, let's talk about the role of CHWs. So we know that a CHW is someone that is a trusted member of the community, who is recruited and hired from the community that they are charged with serving, who can provide peer support and culturally competent care to help assist patients through education or connections to resources that they need. But CHWs can play many different roles. And I really love this graphic on the next slide, Reha. It sort of outlines CHWs are just so valuable and so integral to so much of the work, that we do. They can provide direct service, coordinate care, culturally competent care, improving community and individual capacity, coaching. I mean, we go on and on, outreach, advocacy, assessments, screening. There's so many roles that CHWs can play, and I would say that we can even take this one step further, and we're going to get into that in just a second. But if you haven't already, it sounds like a lot of you already are, which is fantastic. But we know that CHWs are absolutely vital. They're cost effective. There's been many analyses, a strong evidence base that shows very positive returns on the investment for CHWs. So if you're thinking about expanding that capacity, certainly it is cost effective. They're being leveraged for screening and referral efforts. We're seeing that pretty consistently. But we would also say that CHWs, to take this to the next step, how do we move beyond just screening and moving into action, right? We would argue that CHWs can be leveraged for the purpose of building out those referral networks and those partnerships and maintaining those partnerships necessary to not only connect patients to the resources that they need in the immediate sense, but also the partnerships that we need to build to create those upstream solutions to address housing and address those insecurities. CHWs are very well positioned to play some of these roles within your health center. So let's talk about it. Referral networks and partnerships. These are absolutely critical. As we mentioned with the wrong pocket problem, health centers cannot do it all. Sometimes it feels like we're being charged to do it all. Not only are we responsible for health outcomes, but you also need to help people find housing, and you need to help people with transportation, and it's a lot. how do we collectively tackle this? And that is through partnerships and building out really robust referral networks. Um, when we talk about upstream solutions, right, this really, really speaks to housing because of just, as I mentioned earlier, how long it takes to get new housing online in a particular community requires intense community effort at times, depending on the location in the country, your funding streams available in a particular state. There's so many factors that need to come into alignment in order to get new housing into a pipeline. But we will never be able to get there if we don't start thinking bigger and more upstream beyond how do we have to do the individual work. How can we connect this individual patient who's experiencing housing instability or homelessness to their needs immediately? But at the same time, how are we thinking bigger and strategically as a community? How are we forming partnerships to try to, instead of trying to connect folks to the already limited resources that aren't meeting existing needs in our community? How are we creating new resources to meet the need at the same time, long term? And so I would encourage everyone to start thinking bigger. How can we leverage this data? How can we create partnerships to start to plant the seeds that might sprout, that are going to sprout in the future for more positive, deeper rooted change? So we're going to put up a little poll. I'd love to know, just real quick, if you have some partnerships in place, and then let me know in the chat. If you do have partnerships in place, we'd love to hear about them. I did see one individuals say that they had partnerships with their continuum of care, which is fantastic. Um, if you have partnerships, even if it's not for housing, perhaps you have partnerships to address transportation or food insecurity or other SDOH needs. Let us know. And I'm looking at some of these results coming in, and it certainly looks like there's some form of partnerships in place. And then some folks don't have partnerships, right? There's still a lot of room for growth in this cross-sector partnership. Um, and I see some folks in the chat. Yep, trying to reach out to universities for trainings for CHWs. Excellent. And some states have more formalized training standards and curriculums for CHWs. Others do not. Here in my state, I'm based in Massachusetts. We have a licensure. We have a board of certification for community health workers with specific training requirements. Thank you to everyone for this poll. This is very, very interesting. I see that looks like the vast majority of folks have their partnerships centered more on referrals and sort of resource information sharing, or some have informal. About 30% of folks, which is pretty good, have formal MOUs, memorandums of understanding, memorandums of agreement in place. So about a third of you all, that's pretty significant. That's excellent. Regular meetings. 17% have data sharing agreements. Excellent. So it sounds like, everyone's experience kind of runs the gambit. And I think that's reflective of what we know from speaking to health centers on a daily basis, weekly basis across the country, that some folks are just getting started and some folks are a little bit more ahead of the game. But I think we all collectively understand that we can't do it alone. Cross-sector partnerships are the way forward to address these needs. And so speaking of that, we're going to zoom in on a key partnership that I certainly think is so important, which is the homeless response system in your community, that continuum of care, that COC that I mentioned before. Here at Corporation for Supportive Housing, we also do, not only are we an NTAP, National Training and Technical Assistance Partner under HRSA, Bureau of Primary Care, we're also a TA provider under the HUD, the Department of Housing and Urban Development. So we work with continuums of care across the country. And what we know from our work as an NTAP here is under HRSA, as well as on the HUD side, is that a large majority of health centers are not engaged with their community, with their COC. One recent number I can cite, it was less than a quarter of health centers in one recent data set that we collected indicated any sort of partnership or connection with their continuum of care, which is really interesting to know, considering that we know that the housing crisis is getting worse nationally. We certainly, now that we have all this SDOH data, the most recent UDS numbers that we shared earlier, over 500,000 patients screening for housing instability, 1.3 million experiencing homelessness, but less than a quarter of health centers indicating a partnership with the homeless response system in their community. And so let's talk about it. A continuum of care is a planning body in your local area that is a group of organizations that serve people at risk for or experiencing homelessness. So that could be homeless shelter providers, housing providers, domestic violence providers, legal aid, healthcare, of course, should be at the table, immigrant services, you name it, refugee services, you name it. Um, the shape of your COC is not uniform across the country. So it could be a county, it could be a city, it could be it depends. The geographic footprint will depend on where you live, and it will depend on what state you're in. If you're in a rural area, it's most likely what's called your balance of state. So they'll have maybe a few key metro areas that have their own, and then the rest of the state is grouped in one and sometimes is led by perhaps a government agency at the state level that will lead that. Some COCs are more active than others. But the idea is that they organize all of their homeless response providers around a single table. They do coordinated outreach, assessment, and prioritization for resources, otherwise known as coordinated entry. They track data in the Homeless Management Information System, HMIS. They do the PIT count, so that's that one-time count every year of homelessness, one night in January, and then they coordinate and apply collectively for federal dollars to manage housing, and then there's other federal dollars that are applied for to run shelter. So to access your housing resources through your COC, you're in theory supposed to be able to go through coordinated entry. In practice, some COCs are behind on implementing coordinated entry, although they should have it in place by now. Some communities are still behind. But for high functioning COCs, they should have a coordinated entry system in place. And this is how each COC determines who gets the limited housing resources, because as we've already established, there's never enough. So we have to establish a process for how we dole out what little housing resources we actually have. So certain agencies will make referrals, you do the assessment, and then you get placed on the by name waiting list to divvy up those resources. Each COC gets to determine for itself who and how they prioritize. Some communities will say, we want to prioritize homeless veterans or homeless seniors or homeless families with children. HUD does not dictate that. The individual COC decides collectively how they want to prioritize. And the best way to weigh in on that is to join and let your voice be heard around these tables. If this is something that you're seeing in your community, and certainly as I've demonstrated, HUD is strongly encouraging COCs to bring healthcare partners to the table in their communities if they have not already done so. And so there's strong incentives there. And then just a quick reminder about there are competing definitions of homelessness, right? And that's something that we have to just call out. HUD operates under one definition of homelessness to make you eligible for resources through coordinated entry. HRSA supported health centers operate under a different definition. So in order to access resources through coordinated entry, through your COC, a particular patient would have to meet that definition of homelessness. So just something to say, it's just another one of those things that definitions matter, and that being able to speak the language, cross-sector language, is so important to being able to facilitate access. Furthermore, COCs, while they primarily serve individuals that are experiencing literal homelessness, in some COCs, they have what's called diversion or homelessness prevention dollars. So if someone is at risk of homelessness or has or could be avoid homelessness by some immediate support, a lot of COCs have those prevention diversion services. So even if you're not serving a large majority of people meeting the literal definition of homelessness, but maybe rather at risk of homelessness or just housing instability, there is still an incentive to join your COC because they very likely have those diversion resources as well. COCs also have strong partnerships and membership from their DV for domestic violence providers in their communities. So, being well connected to your COC positions you to be able to serve patients that are experiencing or fleeing domestic violence. So there's many, many reasons to join your continuum of care and to participate. So if a patient, you can go to the next slide. Thanks, Reha. If a patient meets that definition of HUD-defined homelessness, you can access or make that referral for patients to access housing resources through coordinated entry. They are screened, they complete an intake, they go on the by name list. But the only way to really tap into this is to become deeply familiar with how your individual COC operates because it's not uniform across the country. Some places use what's called no wrong door, meaning you can go to any member agency in that community and they can assist you with doing the intake assessment. So the example I provide here is the Wisconsin Balance of State COC. That's the approach that they take. In the state of Connecticut, however, they use a centralized process. So they have a 211 hotline that you call, and then they connect you to the appropriate people to do the assessment. It's much more centralized. And so every COC is different. And so in order to tap into those resources and establish these partnerships, you have to familiarize yourself with what's happening, in your particular community. So let's talk about it. A lot of questions that we get from health centers when we talk about partnerships for housing. What is a health center's role in a COC? What roles and responsibilities? How do we make this more formalized rather than just giving a phone number or referring out to an agency that'll do the assessment for coordinated entry? Health center has so many roles. Oftentimes, as I mentioned before, there might not be any healthcare providers at the table. There's a significant rise in encampments, unsheltered encampments across the country. There's a lot of outreach. Homeless outreach workers will go to encampments to try to connect folks to services that they need, but partnering with health centers that might already have mobile services, for instance, or mobile van, being able to partner with homeless outreach workers to service encampments, that is a major a part that they can play. Being able to partner with housing providers, perhaps that are serving individuals that are managing chronic conditions such as HIV or Hep C, and there's just so much value that can be that health centers bring to the table in these spaces. So another question is, how do we make this more formalized rather than just referring someone out with a phone number to the agency that handles assessments and intakes for the COC? So the answer to that is by joining. So you can easily join your COC in any community. And we can drop a tool in the chat, but HUD has a wonderful tool where you can type in your location and it'll give you your primary points of contact for the primary organization. That's your collaborative applicant for your COC, so that lead agency for all the providers at the table. So you start by joining. But if you really want to level up in how you're ensuring that your patients can really tap into the housing resources that are in your community, and your COC controls, I would say, a significant portion of your housing resources, is certainly not all of them. There's resources that come through public housing, which is outside of the continuum of care. And then, of course, there'll be other housing providers that operate that maybe don't serve people directly experiencing homelessness, but are nonetheless affordable housing providers. They might already be at the table for your COC. Your COC is just an excellent way to start making those housing connections, but it's certainly not the be all end all. But the one way to really level up, and you can go to the next slide, please, Reha. So you join your local COC. But if you really want to tap into it is to consider becoming what's called a COC access point. And an access point is where an individual who they're referred to an access point to do the assessment and intake in order to be placed into HMIS, the Homeless Management Information System, and the by name list, so that they can become eligible for those limited housing resources in your community that come through the COC. And health centers are very well positioned to serve as access points in their community. These are some steps that you can take to do this. So you join your local COC. They often have committees. There might be a coordinated entry committee, data committee. There's other committees. Look at your own data. Examine your own internal SDOH data. If you're in that stage right now where you're just collecting the data and you're looking at it, try to understand, are we dealing more with a patient population that is housing unstable or literal homelessness? What would make the most sense? Try to understand what some of their needs and barriers are. Familiarize yourself with the local process for coordinated entry. What's their prioritization and referral? Are there certain subpopulations that they are prioritizing on that list? Does that align with your own patient population and data? If it does have significant overlap, then considering becoming an access point would be really smart and beneficial for you because it will remove barriers for your patients. Talk to the other members around the table at the COC. Do they need more access points? Perhaps they do. Or maybe they utilize a no wrong door approach. But if they have certain access points that do the assessments and intakes, do they need more? Is there funding to support that? And then finally, look at your own internal capacity. Community health workers are an excellent resource to play this role, to attend your monthly continuum of care meetings. They're already for a lot of folks are already doing SDOH screening. It would not take much more to include assessment and intake for your continuum of care. And there's something very powerful about screening a patient for housing insecurity or literal homelessness, and then saying, well, we can take you right down the hall right now, and we'll get you assessed. We'll do a quick intake, and we're going to get you on the by name list today. There's something very powerful about being able to do that in-house, as opposed to having to refer out to another agency that will do the assessment and intake and all the potential gaps for someone to fall out of the process along the way and ultimately not get connected to the housing that they need. This removes barriers and pitfalls by bringing it in-house. So these are some critical steps to consider. And think about, do we have capacity for this? And it starts by examining your own data and talking to your local COC, even if it might feel like a really big lift, like, oh no, we can't take on more, the access point, it sounds like a lot. It might be, but it also, it's nothing hurts by having a conversation with your COC, joining that continuum of care to find out, okay, where is the overlap between our patient needs, what housing resources are available in the community, and what is the need of the providers at the table. So some follow-up action steps, like I said, take a look at your internal data, talk to your local partners, and then you might want to, so if you could go back one slide, please, Reha, that would be so great. Think about how you're using your collected SDOH data. How are you examining it? How are you using that to determine what partnerships are necessary? Who's in charge of managing those partnerships? Having a resource directory with phone numbers is great, but we need to take it one step further by having an individual that's charged with reaching out, formalizing those relationships, knowing the people involved, knowing the intake process, and managing those relationships in order to remove as many barriers and pitfalls as possible. And then finally, starting to build out that referral network that's reflective of what you're seeing in your data. And if possible, formalizing those partnerships with MOUs is the strongest way, certainly. All right. I know that's a lot. So I'm happy to take any questions. Okay, I see one question. Can you share the use of Medicaid dollars for housing referrals and applications? So that is certainly a complicated question, but I'm happy to answer. So as briefly as I can. So for states that have Medicaid expansion, there are certain mechanisms under Medicaid, either through a state plan amendment or a waiver. And we're not going to get into the details of both, but basically you can apply for this mechanism under Medicaid if you're in an expansion state to bill Medicaid for what's called tenancy support services. And so while Medicaid will still not pay for rent or sort of those hard costs, they will pay for other things that will sustain someone within their housing or one-time costs to support or alleviate housing as a sort of a concern. And every state is different. If you go to csh.org/HRSA, we have like a wonderful map that'll show you where your state is in terms of utilizing Medicaid for this purpose. Massachusetts is very advanced in how they're using Medicaid dollars for this purpose. Minnesota, California, there's quite a few states that are tapping into this, others that are in the planning stages of doing so. Thank you so much, Bethany, for sharing that one, that resource in the chat. And so if you're in one of those states that is utilizing these mechanisms under Medicaid, this is really fantastic because while it's not going to solve anything by itself, it's opening up another funding stream that will support the services that are necessary to house the most vulnerable people that we serve. So it's and that's always good. More resources are always good, even if it's not as comprehensive as we would like it to be. And if you're in a state that is not currently an expansion state or planning to engage in this, advocacy. Great. I just want to thank everyone so much for the great questions in the chat and the engagement. And I just want to welcome, we have a special presentation from our next panelist, Sonia Deal, who's the Vice President of Community Health and Engagement for Afinia Healthcare. So thank you so much.
Good afternoon, everyone, and thank you for everyone for joining today. Today, I'm going to share some general information about our CHWs at Afinia Healthcare, and we'll also share information regarding our housing partnerships a little bit later. Next slide, please. So this is just a brief synopsis of Afinia Healthcare. We are a federally qualified health center located in the metropolitan area of St. Louis, Missouri. We currently have 13 sites that include 3 school-based health centers, and we just opened our brand new site that is co-located within the YMCA in North County of St. Louis, and it just opened this past week, so we're excited about that new partnership. And at Afinia, we see approximately 40,000 patients annually. We also have a few different teams that work with with populations, with the community, and that is our unhoused team and our community health workers. Our unhoused team works with those individuals who are actually unhoused. They go to encampment sites, shelters, things of that nature. And our community health workers work within the community and also internally throughout Afinia Healthcare. Next slide, please. So Afinia Healthcare has a team of community health workers who operate in several different areas of the health center and also in the community. Their roles include the facilitation of communication, between the provider and the patient. And also the community. They act as a community voice as well. They work to build relationships and rapport with the community, the patients, and also organizations that they work with. Our CHWs also educate patients and the community on vast topics regarding health and social care, and they assist with the navigation of health and social systems. They advocate for patients and community members working with different systems to meet the needs of the patients and provide informal counseling for the community members and the patients. The CHWs at Affinia Healthcare utilize the Prepare tool to gather data and utilize that data to determine the needs, future partnerships, and then future programming as well. And so we began our journey with CHWs within our maternal child department, and the maternal child department implemented the Prepare tool through the CHWs with our pregnant women who were coming in for prenatal care. And one of the things that we found was that it was important to identify certain social determinants of health through those different populations because we wanted to make sure that we were meeting the need and decreasing maternal and infant mortality at Affinia Healthcare and throughout the state of Missouri. Next slide. So this slide just provides some different information on the programs where our CHWs are actually embedded into practice or a specific workflow. So for our hypertension clinic, we actually had a CHW embedded within that hypertension clinic. Next slide, please. So I previously stated that Affinia Healthcare utilizes the Prepare tool to begin to gather data on the community members and the patients that we serve. We utilize this information from the Prepare tool to guide programming in the health center, to also determine future collaborations with external agencies and also internally. And then the data that also, it also helps us to guide and determine future partnerships to address social determinants of health based on the information that we obtain. So from the data that we obtain, we work internally to guide the need for navigation throughout our own health system. And then we also provide different programs and different resources to the community as well to our own patients. So on the right side of the screen or on this slide, you'll see the different programs that have been formed based on the data that we've received. Next slide, please. So these are a few of the partnerships that have been shaped based on the needs of our communities as identified by the Prepare tool and our own community needs assessment. So later, I'm going to focus on the partnership with the St. Louis Public Housing Authority. But as you can see, we collaborate and have partnerships with several different local, national, and state agencies. Next slide, please. So a few of the challenges that we faced or are currently facing is data shaping, data sharing, partner roles, of course, sustainable funding, which is something that we look into, and not on this slide, also supply versus demand. So as you can imagine, when partnering with different organizations use their data in some way to guide them strategically. So when you're looking at working together, oftentimes trying to figure out how we want to collect data, how we want to shape and share the data in an organized fashion can be a challenge. For these challenges, we focused on the partner roles, what data they were currently gathering, and how the data spoke to the initiative that we were addressing. So housing being the focus for today, one of the major issues with Affinia Healthcare has definitely been the demand for housing with a very limited supply of housing. Affinia Healthcare has been working with our local housing authority and other housing agencies and providers, where our Director of Community Health has been instrumental in developing a relationship, not only for the patients in need, but for those community members who are also in housing, but still have other health needs. So we've utilized those relationships that were built to address the needs of the unhoused, but also to improve the health and navigation of systems to those who are already housed. Next slide, please. So if there was anything that I would focus on, it would be to think outside of the box. On this slide, it would definitely be to think outside of the box. One of the partnerships that we built was with a firehouse, and that firehouse partnership knew the needs of the community. They knew the housing units and the public housing units that were in need of certain services. So it was important for us to focus on the firehouse, building that partnership, and then working through that firehouse to actually address some of the needs of those in public housing. So also as a healthcare provider, we have shifted our focus to address social determinants of health. Affinia has been working with the disadvantaged populations for over 100 years. And for the past 10 years or so, we've been laser focused on addressing social determinants of health to remove barriers, locate resources, educate the public, and assist with navigation through multiple systems. So I would definitely say partnership is a must. Oftentimes, the community health workers live in the communities that they serve, and they serve as that community voice. So it's important to embed community health workers not only in the community, but also strategically place them within different areas of the health center. So some of this slide talks about some of the successes that we have had through our CHW partnerships, both internally and externally. And we have been able to improve blood pressure, also work with our hypertension clinic through our partnership with our internal clinical pharmacist. We have also link community services or community members to different services, and just a wealth of other things that the CHW supplied. And now I want to spotlight a few of our partnerships with housing agencies. So thank you for the previous slide. So one of the partnerships that we have had with a housing agency is the Clinton Peabody projects, and it is the oldest housing partnership within the St. Louis metropolitan area, and it is also the largest. So with Affinia Healthcare, we wanted to make sure that we were reaching out to those who are not only in need for housing, but those who were in housing that were having other needs that they needed to have met. One of the things that we did was we met with the Public Housing Authority, and we set up an event to announce the partnership between the housing unit and Affinia Healthcare. And we had a block party where we provided resources, we provided information, and we also conducted the Prepare tool on site. We wanted to know, we had an idea of what was important for the community to thrive. However, we wanted to know what the community members needed, and so what their vision was. And in doing the Prepare tool and the community needs assessment within that specific community, we were able to see that, yes, health was something that was important to them, but there were other things that were priority. And that helped us to shape that partnership where we started to provide different community events. We also collaborated with other trusted agencies and provided resources and education through those other trusted agencies to that specific community. A couple of other things that we've done is we've, shown up through other community partnerships with housing. We've had an ability to assist with bringing those needed services to the community. And so we have been able to assist with navigation to emergency housing, as well as get those community members that needed care and needed insurance. We were able to get them connected to those things. Next slide. So this is my contact information. If there's any questions, I will take them.
So thank you so much, Sonia. It looks like we do have a few a few questions in the chat relating to the entire presentation. So why don't we take some of the questions, and folks can, if you have specific questions for Sonia, please continue to drop them in the chat. But I wanted to circle back to some of the questions we had from earlier, which is how can health centers gather their voice to work with their local political leaders to invest in housing for the vulnerable? And this question, I think, must come from folks in Hawaii, because Hawaii was thinking about using Medicaid dollars to build housing, but that is not viable. So I wanted to address this, and Sonia, I know you probably can have an answer for this as well. And I wanted to just kind of say, how do you gather your voices? Well, again, I'm going to go back to saying your continuum of care is labeled as that homelessness response system. However, the providers at the table, yes, they're serving the most vulnerable, those experiencing literal homelessness, but you're also having folks, affordable housing providers, other nonprofit housing providers that are serving folks experiencing homelessness and doing workforce housing and doing low income housing. You're going to have public housing authorities at the table, all essentially most of the relevant players in your community that are relating to housing and housing advocacy are at that table already. And they already have different strategies on how they're advocating for some of these things, or perhaps you can bring your ideas to that table. There are also other housing advocacy coalitions in every state, in every major city. So reaching out to those folks and lending your weight as a healthcare provider, speaking from the point of health, is so valuable. And housing providers are very eager to embrace your partnership. Certainly, we hear that on a regular basis from the housing providers that we work with nationally every day. And then for this, doesn't have a name attached to this question specifically, but if there are others in Hawaii that are curious about this question, there is an excellent example. Waianae Health Center in Hawaii has an excellent model of how they have worked with their local encampments. Their encampments have done some significant organizing amongst themselves regarding housing advocacy. They do excellent housing and homelessness outreach. They have a full staffed outreach team. We have a paper where we've spotlighted them on their work with coordinated entry. Waianae Health Center, for those that are in Hawaii, excellent program. And I don't know, Sonia, did you have something to add to that question about how folks can lend their voice?
Sure. So we actually participate in calls with our continuum of care in Missouri as well. And we do also work with different agencies. Just yesterday, we presented at a panel in one of the neighborhoods within the North City of St. Louis. And there we had several different organizations that were actually working towards housing and working towards addressing economic stability within that specific community. So being at the table and just being a part of that conversation was also important, because we had educators, healthcare providers, bankers, developers, all in one space to really speak to the issues of housing and economic stability in those vulnerable communities.
And then I would also say, to comment on the question, they said they wanted to use Medicaid dollars to build housing. Now, you can't use Medicaid dollars. They said in the question, it's not viable. And that's true. You can't use Medicaid dollars to build housing. But if you're in one of those states that's wielding that mechanism under Medicaid to fund services, that can be leveraged with other funding sources and braided or blended together in order to get a viable housing project off the ground. It's not the be all end all, but it's one more resource towards getting the actual housing units off the ground that we need. That we have lots and lots of resources at CSH as well as the National Clearinghouse for health centers that are really interested in taking that upstream solution, that upstream approach, especially through if you're considering capital expansion or adding an additional site. There are many, many examples across the country of health centers that have invested and created new housing units for their community to be the active change agents, right? We don't have enough housing, period, as we have established. There's years long waiting lists. Even if you can make the referral, make the partnerships, it's certainly not going to, we need to build more housing ultimately. And health centers can play a very vital role as a partner in that process and to helping to plant the seeds going forward. And it all starts with reaching across the aisle, so to speak, to form those partnerships and start having those conversations and showing up at the table. And Sonia, I think we have a few more questions for you. It says, with 43,000 patients at your FQHC, how are positive SDOH screenings tasked to your support staff within your EHR system?
Yes. So we
Great
actually build a task box for those community health workers where they are able to not only distribute those tasks, but also to engage with those patients. We also have a system where we have the community health workers to go out to different sites to gather information, to gather clients. We assist those clients on site as needed, as well as in the community. We have different events where we actually poll the community and the community members for any social determinants of health while we're there. And those CHWs actually work through those clients as well as help them on site from a community perspective.
That was a great question. And we have another good question, if you're up for it, Sonia.
Yes.
How do you recruit and obtain CHWs? We've been trying through outreach and job postings to no avail. And what evidence have other folks brought to their administration to show that CHWs are worth the investment? So this question is for Sonia, but if others want to sound off how some of the strategies they have used at their health centers, please do so in the chat.
So for us, it is important for us to make sure that we are getting CHWs from the communities or the populations that we are looking to serve. For instance, for the HIV CHWs, we want them to have an understanding of what HIV is. We also look for individuals who may be LGBTQ plus IA. We want those individuals to apply. So we do market our services. We market the jobs, the open positions that we have. We have CHWs that work with our COVID teams. We actually look in the communities that we are going to serve. And we try to market to those specific communities, such as our refugee and immigrant CHW. We wanted someone who's actually gone through the system of becoming or coming to America, coming to the United States from another place, being a refugee or an immigrant, and having gone through those services. And what does that look like for you? Because then they're able to better speak to individuals who are coming through immigrant services and looking to find healthcare, looking to find housing. So we actually partner with International Institute in St. Louis, Missouri, and we work with them to identify those individuals that are in need, but then also just to provide services for them.
That's a fantastic way to recruit community health workers, is through your partnerships with the International Institute. What a great strategy. I also see another comment from folks answering that they have partnerships with their local community college for a CHW certificate program.
Yes.
So that's also another way to answer that question. And what about having to speak for return on investment, for building that support, for expanding capacity of your community health worker team? I mean, certainly I would say there's lots of evidence base that we can point to. There's been many analyses that show that there's cost-effective return on investment, and there's many of those resources we could share with you. But I think the most powerful argument, and let me know if you agree with this, Sonia, the most powerful argument is, looking at your own internal data and saying this is a need that we're demonstrating through our own collected data. Our patients have these demonstrated needs. We don't have present capacity to take steps to assist them with navigating the resources that they need. Therefore, we need to increase capacity in order to move the needle. But what do you think, Sonia?
Sure. So one of the things that we have done, again, we look at our data to see what is the need, where can the CHW fit in or be embedded in that specific workflow or that specific department. And of those things, we've actually built, a program or a workflow for the CHW for let's just say for hospitalizations, where we see that implementing a CHW to do that prepare tool, find out what that patient needs before they are discharged from the hospital, and then starting to work different systems and find different resources before their discharge or shortly after their discharge, that decreases the readmission rate within 30 days. So again, just looking at a specific workflow or process and looking to see where a CHW embedding that person or that specific workflow into, or that CHW into that workflow can definitely be of assistance.
I love that. That's great.
And we do the, PDSAs to see, are our efforts, are they getting us the return on investment? Are we reaching goals? Having that CHW embedded within that specific workflow.
Thank you so much for that, Sonia. And I would also say, we had a question as a follow-up. Is the workflow that you implement within the Epic EMR system or another EMR?
It is within another EMR. So we actually utilize NextGen.
Okay. And then I also wanted to just give a quick plug to follow up to this for the one individual who asked the question about recruiting. As you all know, we are also streaming live on YouTube, and in our YouTube audience, there was folks from WePair, which is a digital platform for CHW job matching, so sort of a workforce solution. So if there are other folks that are identifying with that question, that you're having trouble recruiting, perhaps check out that resource. So thank you to who submitted that from our YouTube audience. Great. And then I also want to shout out a comment in the chat that says, that retention of CHWs is difficult. Have you experienced that, Sonia? And have you taken steps to address it?
Yes, we definitely have. We have had the pleasure of hiring on and sending CHWs through school. Majority of our CHWs have had, they've had some longevity here, but we have had some turnover. And of course, right now, within the nation, it's kind of hard to find individuals who want to go into certain fields or certain work. And again, we look to the community. We want to have someone from the community that we're serving, because again, how better to understand that community than to have someone who is potentially a voice for that community.
Absolutely.
Yes.
Absolutely. Great. So please continue to send in your questions in the chat. If you have any more questions relating to Sonia, for myself, relating cross-sector partnerships, community health workers. So I think I just overall our conversation just speaks to how do we increase access to the social determinant of health resources. There's many avenues. It involves looking at our data. It involves building out extra capacity, and then it involves forming new cross-sector partnerships, which ultimately can yield so many positive things so many positive things as it relates to those upstream solutions. And we have many great examples from health centers across the country that are taking steps in a variety of ways. I can think of yet another health center that I worked with last year who had a robust community health worker team, and they added a housing navigator to their CHW team in recognition of, okay, we're screening for social determinants of health. We're seeing a lot of housing instability. Folks are having trouble finding the housing that they need. So we're going to add a housing navigator. That's another role that CHWs can play. So CHWs are so valuable. And we certainly cannot speak more highly about their valuable role in certainly in every health center. And then I have one more comment. I see, thank you, Bethany, from our YouTube audience about partnering with developers, so housing developers. And that actually speaks to, again, that upstream solution. Health centers are excellent, well-positioned partners to actually be part of the solution, right? Which is ultimately that we need to add when we're spotlighting housing today. So to add more housing to your community, there's so many pathways to do that. And certainly our audience on YouTube is reflecting that, partnering with housing developers, thinking about how a health center can add value to a partnership or a project that's going to bring online more affordable housing in your community. Something to think about. And if folks have additional questions or want to dive deeper into some more of those upstream solutions around housing, please reach out to me. Check out our resources, csh.org/HRSA. Great. Any final questions for
Shami,
Sonia?
there was one question that was placed. It was, how long did it take your healthcare agency to develop the program? We actually had the help of the Missouri Primary Care Association. They worked with us through implementing the community health workers. And as I stated previously, we started within our maternal child team because we knew that the mortality rate of our mothers and our infants was high. Was higher than the national average. And so we wanted to address that particular subset of individuals first. So getting it off the ground and started, we actually got the program up and running. It was within 12 months. However, moving the needle on things and actually tweaking things, it took us probably 18 to 24 months to really get a good flow going.
And then we have a couple, since we have about 9 minutes, and we have some more questions coming in, I'm just going to keep it going here. Sonia, could you talk a little bit about the strategies that have worked for your center to improve closed loop referral rates?
Sure. So one of the things that we did, we actually developed our own protocol where a CHW has specific points that they need to make sure that they're meeting with community members. So upon the initial visit with the person, they have to reach back out within 3 days, 7 days, 14 days until that actual alert is closed. And where there may be a person who has multiple alerts or multiple things that are needed to be addressed by the community health worker, that community health worker defines a plan with that patient or that community member to say, okay, this is what we're going to work on first. And, they ask the community or the patient what is important to them, because again, as a patient-centered health home and a patient-centered medical home, we want to make sure that we're including the voice of the patient in their plan, as well as making sure that they are the core of that plan being created. So once we do that, we follow up using that system, and we develop the protocol around it.
Thank you. And then we also had one more question sort of relating to the differences and overlap. It's a pretty good question. Let's see. How has CHW role growth impacted the role and recognition of opportunities for social workers trained with bachelor or master's degree level competencies?
Sure. Sure. So we have CHWs who, we don't have a CHW who is a social worker on site, but we do have a CHW who is a registered medical assistant, and she also has her associates in healthcare administration, and she's now our director of community health, and she supervises the other CHWs. So there is definitely a potential for role growth. I believe that there are several different avenues for not only just lay members or community members to become CHWs, but also those who are professionals. In the state of Missouri, I know that we have a team of social workers who are community health workers. They saw value in going through the programming and completed that programming.
And it looks like we had one more follow-up question as far as the workflows. Are the referrals coming directly from the provider or care team? How is that workflow implemented, or is the medical assistant or RN sending the referral to the CHW or the task queue? It's very specific, but
Sure. So for CHWs internally, we actually have a few ways that a referral can come through for CHW. That is internally from the care team as well as for providers. And again, in our task box, that a task will be sent to the community health worker, but also we developed a community referral form for all of our partners. In any community event that we attend, we bring those community resource referral forms because we know that there are needs in the communities that we're serving. We want to make sure that we're not only collecting the data, but also following up with them. So we have this community referral form, resource referral form that a person can fill out while they're at the event, or they can take it with them and send it back to us. And that's another way for referrals to get started.
great. Well, we are about at time. I just want to thank you so much, Sonia, for your presentation and your just thoughtful reflections and answers to these questions. For folks that are still with us, please take a moment to click on our SurveyMonkey. Your evaluation feedback is so helpful to us as we craft our training and technical assistance. As a reminder, this is part one of a 4-part national series, so I do hope that you'll join us for the remaining 3 sessions where we have excellent topics, panelists, and further in-depth discussions. Please reach out to us at any time to ask questions. You need follow-up technical assistance. We are certainly here, and be sure to view all of our resources in the National Clearinghouse. Thank you, thank you, Chloe. The evaluation link is also in the chat. We very much appreciate all of your really thoughtful questions, as well as everyone who joined us live streaming on YouTube. Our next session is December 7th, where we're going to talk about healthcare workforce challenges in part 2. So stay tuned for that. And I hope everyone has a wonderful rest of their day.